disease, Parkinson's, and addiction disorders, among other areas. His lab has focused on pioneering radio tracers for imaging targets such as microtubules stability, with applications in Parkinson's and Alzheimer's. In 2023, he was named a distinguished investigator by the Academy for Radiology and Biomedical Imaging Research, and he most recently received the Innovators Award from SNMMI, that's a Society for Nuclear Medicine and Molecular Imaging, whose meeting is actually here in LA, and that's why he's visiting us in 2025. And that was through the Mars Short Research Fund for his work advancing PET imaging of microtubules in Parkinson's. So that's the topic of his talk today, how to apply these new tools and methods, but for Alzheimer's. So let's welcome Kiran.
Can you hear me? Okay. All right. Thank you, Shantanu. Thank you, Will, for the kind introduction and invitation. I'll tell you a small story how UCLA is connected to me. Back in the day in 2005, I did apply from India for this school to get into the PhD master's program. I did not get it there. It's a full circle now, and I'm coming back here as a speaker. I was telling one of my friends, in fact, my professor there, like, I mean, it's how cool it is to come and visit the campus, because UCLA is big in the chemistry program. And I was really wanting to get master's and PhD here. But anyway, I did get it in Chicago, Northern Illinois, where I got my master's PhD and moved into this part. Thank you so much. Moving something into my work. So this journey of mine started literally 13,000 kilometers away. When I started from India, moved here in 2005, got into Northern Illinois University, got my PhD in mechanistic organic chemistry from Dr. Klump lab, both master's and PhD there, and then moved into WashU. That's pretty much where the whole my life-changing turning point. I didn't want to go into a typical organic chemistry lab and do synthesis, which is nothing against, but I want something more real-time to see my work in people. So that was my motivation, and that's where I really switched tracks and went to radiochemistry, and no other place than WashU to get really trained there. And WashU being almost like a premier place for a lot of radiochemistry, molecular imaging work, and Bob Mack was there. Of course, Mike Welch was also there, was almost retiring, and Bob Mack was leading the whole radiochemistry space, and I was his last postdoc at WashU, and he's now at UPenn. And I went to Wake, Dr. Mintz, nuclear medicine physician, who hired me there. It's almost 11 years that I've been at Wake Forest. Started the place to just run the show, and now you will see a couple of new things that I'm working on. And research is very personal to me. And my grandmom died very early of early dementia. We don't even know what happened. Like within a month or two, she literally disappeared. Like she passed away, and it was so traumatic for all of us. Like 1 month, that's it, and dementia happened. And first, we don't know the tools, and B, access. We don't even have access to a lot of these tools back in India. And it really moved me, and she was very personal to me, and understanding of the disease was there, and that really had a passion for me to develop better tools for early diagnosis, and it did start much early on in my life. So since I can't take you all to Wake, I want to bring Wake here. So I want to show our facility with small images. We have one of everything, not like the super heavy like UCLA. We don't have multiple things. We have one cyclotron, which is GE PET trace, and 4 active hot cells, which house all these modules, as you can see here. We have tracer FXC and all traces and the 2 GE boxes. So yeah, this is Wake PET facility for us. This is the cyclotron we have, which is more for C11 and F18 applications, and 4 hot cells that does the magic with our lab. And since it's a GMP facility, everything is managed here with clean lab. How do I advance? Okay. And this is the QC lab we have. Again, one of each. We have QC HPLCs waters and adjuvant, and we do all the bacterial endotoxin testing before we release to the subjects. And an added advantage is Wake space is completely GMP setup that we can do all the clinical trials actively for any of the clinical studies that we actively do with Alzheimer's and cancer research. And these are the scanners we have. And right now, I was just telling Dr. Wurz, we got upgraded to the Siemens scanner. This is the 4 scanners we heavily use that the research that I'm going to show in my work, GE PET-CT scanners and the trifoil micropet scanner. The beauty of all this facilities, we are in the same floor, like right next to each other. So you're not losing a lot of activity or decaying your half-life. So the specific activity is high. When you're making the compound, the QC is next door and the scanner is next door. So we literally yell at each other, it's good, it's good, it's good, and we inject into the subject. So that's an added advantage. You would appreciate when coming from Washu, everything was on different buildings. So we have to call people and say, after 20 minutes, this is good, and the tracer has to be literally dragged on a cart and go to the other building. But here at Wake, it's next door. The subjects are waiting for you, and the QC is done, and we are like checking, and then we're injecting. And the next room is also the micropet. We do a lot of rodent research there as well. So let's coming back to the first topic, which is very near and dear for me, is the PET imaging of microtubules. So I want to go back with the whole Alzheimer trajectory where we started. So in 1984, we started the clinical pathological era where the whole thing was mainly based on the diagnosis based on the post-mortem confirmation. And 2011, we moved forward with the ATN classification, Alzheimer's, tau, and the neurodegeneration. And right now with 2024, NIA and Alzheimer Association came up with this classification, which is very cool, like amyloid PET is there, CSF, A-beta 4240 and CSF. This is all being done at Wake actively. So every subject gets scanned and get into the CSF and blood biomarkers. And the highlight is tau PET at the core stages really reflects the whole thing. But however, it typically reflects a propagation stage process very closer to the symptom. So the reason why I'm bringing is even though everything is set, the problem is no two subjects will have the same level of Alzheimer dementia when you're talking about the PET scans. For example, they show the same Alzheimer A-beta score, Alzheimer tau score on the PET. But however, when you go into the markers and their clinical diagnosis, they are different. It means there is a lot of heterogeneity happening. So there is a lot of cognitive resilience and resilience happening, which makes us feel like this Alzheimer's is happening much before the clinical symptoms really show up, which is like the 15 years of preclinical show, which much earlier in this space of the whole spectrum of Alzheimer's pathology. Okay, and then this is, I mean, there are so many mechanisms that came forward. Like, for example, we're talking about preclinical phase in phase 1, phase 2, and phase 3. You're talking about all these markers. One is the oxidative stress. People are coming up with these markers here in the phase 1, 2, and phase 2 is more on the inflammation. There are a lot of clinical trials happening, looking at the synaptic loss and the TSPO loss. And then in the phase 3, you're almost talking more in the metabolic phase. FDG is very common, and getting your amyloid and tau PET. And then we're also seeing a lot of PET tracers which are actively in the clinical space. These are all the PET radio tracers which have been run in this country for different clinical applications in the Alzheimer's spectrum. However, the bigger gap is nobody is looking at the axonal transport. What we currently image is after the wreckage happened. Nobody's looking at the collapse. Nobody's looking at the preclinical phases when the brain is telling us something which we cannot predict. So people are only coming to our scanner or to our site when they have symptoms, but not before the symptoms. I think, but we really miss a direct readout of the neuronal cytoskeleton machinery. And that's pretty much when I got this idea of why are we not looking at the precursor of tau rather than looking at after product. So the whole idea of the microtubule started when we were actively scanning patients with the tau PET and amyloid PET. So this particular microtubules, as you all know, is a very cytoskeleton unit. makes a lot of things in the whole neuronal structure. As you can see here, it's very much useful. It's very dynamic process. It's useful for growth. It's useful for all your catastrophe and also in the rescue of the process, meaning it's a dynamic process, should happen constantly, stabilization and destabilization. And it's always stabilized in most of the healthy neurons with the help of tau, which is the microtubule associated protein. But what is the problem with the healthy and non-healthy neuron? As you can see here, in a healthy neuron, your microtubule is very intact. Everything is much stabilized here. Whereas in the case of Alzheimer's, it's all destabilized. It started much earlier. And here we are cutting the tau protein tangles. And this is labile phase and unstable phase. We wrote a very good review article last year to really look into the whole microtubule spectra in connected to Alzheimer's area. So please look into that review article if you are interested more into the microtubule literature. So it's an Alzheimer dementia journal. So what we were interested is, can we really look into this site of the microtubule rather than looking at the disintegrated tau, which happens much later, or that's what the current markers are looking. And the whole paradigm shift, where it's very interesting in the Alzheimer field, is people historically thought the microtubule destabilization is a cause of amyloid and tau depositions, as you can see on my left-hand side. This is what people thought, like microtubules are really viewed as the purely end stage, that is the product rather than the precursor. So where my hypothesis is, why don't we use this as the preclinical phase? Maybe it's happening much earlier. As you can see, it could be an upstream driver rather than a downstream process product of the tau hyperphosphorylation. So the dendritic simplification, all these are happening. Maybe we should look into as earliest pathogenical events, much preceding your classical hallmarks of amyloid and tau. That really drives your synaptic impairments and dendritic simplification. We're also showing people that the microtubule destabilization is very much talking to synaptic impairment. Not showing the data here, but it's very clean that it also happens much earlier before you see amyloid and tau. And that data is being established in the rodent models, and it's working in my lab. We are not the first ones to really show. Back in 1980s and 60s, there are already clean papers that show that the microtubule destabilization happens in the post-mortem Alzheimer brains. As you can see here, filaments from an AD and the filaments from a cognitively normal are being shown with the help of microscope. As in both the cases, this is in people. But no one has really targeted as this into the image spectra. Can we really do it in real time, in live people, in live brain? And that's pretty much where a hypothesis, maybe all these three are talking to each other. The amyloid, the tau, and the microtubule destabilization, almost making like a triad of neurodegeneration. We really need to understand what is feeding what. Is it like microtubule destabilization is the beginning point for these two, or this is the end point? So my hypothesis is like pretty much like microtubule destabilizations happens much earlier than we see your amyloid beta tau tangles, and all your cognitive impairments happen at the later stages. So we do need a image. We do need a tool to image microtubules in real time. I hope I was able to convince you that there is a reason why we are looking at this real-time PET radioligand that can really quantify microtubules in real time, and that to a blood-brain barrier penetrating PET ligand. This is where my group went back in the literature. We want to see what really happens. So this particular field is big in the cancer. There are a lot of taxanes, you all know, are microtubule-based agents. So these taxanes, this paclitaxel, docetaxel have already been made, and people have imaged a lot in the cancer field. But the problem was, when I looked up into all these images, none of them went in the brain. So there were no brain penetrant microtubule ligand that can really be useful for your neuro applications. So that's when my lab went into the translation spectra, and this is Naresh, who really in my lab, who spearheaded a lot of these projects, and he was my first hire when I got this, or before I got this R01. So you will see like how translationally we moved something from bench to bed. So we really went back to the lab, designed a tracer, wanted to see what goes into the brain, and we found this particular compound called MPC6827, which is a phase 4 dropout candidate for GBM. So it's already been used for glioblastoma as a clinical trial agent, but nobody has looked into this as a PET radioligand for Alzheimer's. So which was a low-hanging fruit for me. Instead of really developing something from scratch, why don't we use this? Because all the toxicity studies have been established. So I can convince FDA much quicker route to get me an administration thing into the clinical world. And that did help me. So this is our strategy. We went back to the lab and we did all the, we synthesized this compound and we thought like what could be done. And how we have to, first of all, we have to make sure this compound is really measuring microtubules. And look at this. We have done with all these brain targets, and it's only one target with microtubule. It binds with 1.5 nanomolar affinity. So you know this compound only binds to the microtubules. So we went back to the lab, we did all this test, and we started synthesizing the compound and made it into radioactive. So we simply tagged it with a C11 radioisotope, made this compound into C11 MPC, which is the microtubule PET ligand now. And first thing, which has been automated, we have done it 200 productions or 300 productions by now, and well automated and being used in other facilities as well. Now we finish the design. Now we are moving into the rodent space. We want to see whether it does do what it's supposed to. It goes to the brain. Yes, you can see, as you can see in a healthy brain and in healthy rats, it does go in the brain. And we have done a lot of blocking studies where we put a lot of cold compound in pharmacological doses to see if your radioligand is really binding to microtubules. You can see like 90% of it is blocked, showing that what you have made is very specific for microtubule. And this is the first brain penetrating PET microtubule ligand made to image something in the brain applications. So then, of course, we have to make sure that in vivo is talking to ex vivo. We did a lot of biodistributions at different time points in the healthy mice. And we saw that it is following a very good pharmacokinetics, which means by 60 minutes, everything is washed away. And also did the blocking, clearly showing that it complements in multiple ways, in vivo and ex vivo, that the tracer is very specific. And now we have done like, okay, so it goes in the brain. That doesn't solve the problem, right? We need to understand what does it tracer really measuring. Is it measuring the stabilized microtubules or destabilized microtubules? Because this process is so dynamic in the brain. So we came up with this mechanistic pathway. What we did was in the cell uptake assays, we used some stabilizers and destabilizers. And we found that the moment you add stabilizers, the uptake decreases. When you add destabilizers, the uptake significantly increased. It almost shows that the tracer we made is measuring the destabilization. And we have not only showed with the in vitro models, we have even done some in vivo models. I want to shout out here, like we are using a drug called EPOD, which is a microtubule stabilizer. And that's what I was using in my Parkinson disease model as well. Just to bring it to a highlight that as we use a stabilizer, the same animals at the baseline and the same mouse after we treat has decreased, showing that your tracer is very sensitive to microtubule changes. It's able to pick up changes much early on. So as a radio tracer, if you want to get into the clinical world, you really have to characterize every single thing. We made sure that it has the better pharmacokinetic properties, that the dissociation constant and Bmax have been measured. Everything passes for a typical CNS-based radio tracer. We also have to make sure that its metabolism is very good for a PET radio tracer. And in both rat plasma and rat brains is greater than 90%. So we have to check mark all these things before we go into humans. So everything passed as we expected, hooray. And then next is, this is my R01, where we have done this is the work for almost 3 years. What we have done is we started aging Alzheimer mice. This is the AD mice, which is heavily in the amyloid beta mice. What we have done is look at this from 2 months. We have scanned them for 24 months. We have done wild type and transgenic mouse model. As you know, in the transgenic mouse model, pretty much everything is higher when compared to the age-matched wild type, which is the microtubule uptake. You would expect that to happen. And not just in vivo, we have made sure in biodistribution, we did autoradiography, and we have done something in the mice models. Where I really want to bring out is the behavior test. Look at this very cleanly. Not only that we showed that the AD mice has higher uptake when compared to the age-matched controls. Very clearly, I want to bring it to your attention. Look at this particular thing. At 2 months, you're able to show a significant difference in the brain uptake of an Alzheimer mouse brain, where cognitively it's normal. Only in 10 months, there are some changes in the cognition. So which means microtubule changes are happening much before the cognitive changes are happening. And we were able to show that in the Alzheimer mouse model, that these changes are happening early on, and the tracer is sensitive enough to pick those changes. And this was really a game changer for us to really understand, oh, so this is pretty cool. At 2 months of age, this tracer is picking up the changes of microtubules. And this was almost like selected one of the top papers of last year, 2025 Alzheimer's and dementia. Not just in the amyloid beta models, we also tested in the tau models. We see the same thing, that it happens much earlier than the cognitive derailments happen. So it almost shows that it is tracking earlier than your tau and amyloid depositions in the mouse models. So with this also, we have done a lot of collaboration studies. We have done that positively correlated to Alzheimer loads. We did immunohistochemistry in all these mouse models, pathologies established. We did biodistribution, we did autoradiography, we did also, like I said, immunohistochemistry when negatively correlated to that. So we validated because we want to move it forward in the Alzheimer world, you have to validate it against every single marker. And we did that with the commonly available markers in the lab and at Wake Forest. So hooray, so we moved all these things now. So we finished this, we finished rodents, and luckily Wake, we have access to non-human primates. And vervets apparently are one of the greatest models for Alzheimer's, as the aged models of vervets get typical Alzheimer-like and tau-like pathologies. So I was able to use those non-human primate models, vervet models of Alzheimer's, and we tested them at a younger and an older animals. And we saw that the older animals have higher uptake. Not just that, and again, since Wake has an ADRC and R24 funded, we take their CSF and blood every other year or every year right now to see what Alzheimer markers they have. And luckily, what we found was that it is correlating with a lot of CSF A beta 42 value. This is how it still fits in the same story. As the Alzheimer load increases, uptake increases. And this was happening around the COVID time, and we lost these monkeys. And after we euthanized them, we got their tissues and we did autoradiography in the same monkeys. And look how regionally it is important. The controls were higher, were here, and all the AD-like uptake was much higher in your prefrontal cortex and your midbrain thalamus, pons, hippocampus. And we saw that not just in vivo, but also in post-mortem brain tissues. Again, validating our traces efficacy. And this, I want to bring it to your attention, is this is an ongoing project, not just happening with the 4 monkeys we tried. We are doing it in 16 monkeys twice a year. And we see that the MPC is talking to so many regions, especially for the neurofilament light, which is a neurodegenerative marker. So the story is very strong that it is talking to neurodegeneration much early on before they see the plaques in these monkeys. So our hypothesis so far is microtubule destabilizations happens prior to your amyloid beta and tau depositions, especially before into the clinical phase where you really see cognitive derailments, and could be an imaging marker for the preclinical stages. In preclinical, I mean like before the clinical symptoms, not in animal models. So that's a clarification with always with the Alzheimer's space or Alzheimer research. So then, hooray, we've finished all these 3. Now we can go to first in human. So we went to FDA because, again, I used the analogy because the compound is already a dropout candidate for GBM. So, and then we simply, we learned from the monkeys that all this are happening, that destabilized microtubules and the increases with AD loads and detects changes before, and also behavior changes and A beta formation significantly correlates with the fluid biomarkers. So then we started doing the imaging studies, and this in collaboration with Columbia, because of some restrictions during COVID 2021, we started this study. We got an R21 to look into 6 healthy male and 6 healthy female to just get the dosimetry. What are the doses are being safe? How much are the dosimetry numbers are needed? And everything was in favor for our numbers, and we used this data to go into an R01, which we only got an R56, but was something to start with. So we got an R56 to look into now in the Alzheimer people to see what happens in there. And this is the study, which is a pilot study started 2 years back. what I did was we hire 3 groups of people. One is the cognitively normal subjects who are amyloid negative and amyloid positive. So people who are negative and positive are also there in the Alzheimer's spectra. And then, of course, the MCI people. I got permission to do 8 and 8 and 8, 24 subjects. The main thing was to look into safety of this aspect, how the tracer is safe in the bigger cohort. And then we tried it and did all this stuff. Of course, we do, since Wake has an established ADRC cohort, I really didn't have to reinvent and hire new cohort. I just have to pick people from that cohort who very well fit in this category, and all are age matched, and that's the beauty of it. So the preliminary outcome of my first trial is to look into safety, and everything was saying. And then the secondary endpoint was to look into the empty brain uptake between the 3 groups, again validated with the existing biomarkers. So we did now I'm showing you the 19 subjects, which are very closely age matched within these 3 range. And we did 1 hour dynamic scan this is the study design, and we recorded vitals throughout the PET scan. And we also checked if there are any AEs 24 hours after the scan. And we did a typical ALS processing that happens with any Alzheimer readouts. So the neuroradiologist reads the scans, and a typical way of doing the image analysis with BRACs and MPCVOIs. And first of all, I want to shout out, like, with the safety is very good. We have no AEs reported in my subjects, and the vitals were all stable. And boom, this is the very first time we saw, for some reason, females have higher uptake of this microtubule destabilization. When I combined all these 3 within the 19 subjects, I found a star. And when I break it down into individual groups, also there is increase. So microtubule destabilization may be happening higher in females than age-matched males. Why, we don't know. And again, this is just a pilot scan. Very interestingly, it was shown that it is happening quicker or more in females. And then this is what you would expect. Like, when we did the cognitively normal, this is the uptake. And this is cognitively normal, but A beta positive. These people have amyloid positive. And this is a typical AD subject with MCI and AD. You can see how distinguishedly it distributes between the 3 groups of cognitively normal and cognitively normal, amyloid negative and positive. So the current radio traces cannot distinguish these 2, because both are, these 2, cognitively normal and amyloid positive, these are all amyloid positive. So you need a tracer to really understand when these people become into this. And that's pretty much my hypothesis. Can we use microtubule tracer to detect or predict early on? Can we use these patients and see when these people will become this, meaning when they're cognitively normal or already amyloid positive, when they become cognitively impaired? And maybe microtubule tracer can tell us more information and able to predict much earlier in the spectra. And again, this is, since it's 19 subjects, I want to show it out loud that we were able to see some stars with our microtubule tracer when compared to the tau PET. But when I combined with all of them, look at this, we did not see a lot of significance using the tau PET, which is the AV tracer, whereas with the microtubule, we saw significant differences when I combined all the cognitively normal people into one and all the MCI into one bracket. Same thing we have seen with the amyloid PET, a lot of positive correlation, not a lot of significance, again, with the pilot subject being so low. And what I did was, when I combined with all the cortical regions, it shows a positive correlation with the microtubule PET. Same thing with the tau PET, because it was not necessary to all the subjects to have tau PET. That was not the criteria for my recruitment. So with whatever tau PETs they had, it does show a very positive correlation in the cortical regions. And so the beauty of Wake Forest is all these subjects have all the plasma and the tau markers every time available. So as expected, it has a negative correlation with the A beta 42 ratio. That's what you would see as the Alzheimer progresses. Both the p-tau 181 and p-tau 217 have been positively correlated. So now with this preliminary data, I submitted an R01 to look into a larger cohort, like 75 patients in each of the group. It's been submitted last cycle. It will be reviewed in 2 more weeks. So yeah, with my first project, and this is the first PET radio tracer to image microtubules. Females, for some reasons, have higher uptake than age-matched males, and cognitively normal amyloid negative people has less uptake when compared to the MCI and very positive correlation with not just the amyloid and tau PET markers, but also fluid markers. And it differentiates Braak stages better than tau PET. Is it in established people or much earlier? We have to see when we have some variation in the subjects. That's what we are exploring in the next submitted R01. And what we are trying to see is that we really want to see in the kinetics in humans, healthy humans, to really understand how quickly it goes. Do we really a long scan? Because there are aged people. We want to see where can we get rid of the 1 hour scan instead do 15-minute scan. To understand that, we have to hire, recruit healthy people, and we are trying to understand the kinetics better in healthy humans, and which are like, when I say healthy humans, almost age match, getting into that older spectrum. And preclinical AD human imaging may be an early neuropet biodegenerative or can be used for even other drug studies. I'm going to switch gears and I'm going to talk something about very cool project my lab is also working on, very close to Alzheimer's space, is intranasal insulin. I'm going to show something very cool that PET can do instead of regular doing the amyloid, tau, and your typical microtubule. Something, how do I say this, without needles. Can we do a PET scan without injecting? So as you can see with the title, we're doing something intranasally, and we can use PET in that route. Let's see what we have. So just want to intro on this is now Alzheimer's is almost considered as a type 3 diabetes of neurodegeneration. The reason why I'm saying this is like bigger in the mapping or the mechanistic overlap that you can see in the systemic insulin resistance and cognitive decline. There's a huge number of diabetic people getting into Alzheimer's. So there is 65% of chances of higher risk of developing Alzheimer's in patients with diabetes. And hence, and also with 45% faster decline in general cognitive abilities, memory, and reasoning in diabetic patients. And because of this overlap, Alzheimer's is almost considered as type 3 diabetes. So there is a lot of research going on into looking at the metabolic synergy of why is this insulin resistance so big in the Alzheimer's pathway. So I'm just going back with your mechanistic thing, why the brain's metabolic circuit board of your very common, the P13K and AKT signaling. In normal healthy circuit, your insulin will bind to the receptor and the receptor will get activated, and the P13 will take care of activation and will not let this hyperphosphorylation of GSK3 beta. But what happens in an Alzheimer case, or in a case where you have amyloid oligomers or any mutation in these three genes, is this all gets inhibited, and then the IRS will not go forward, which means that P13K phosphoinositide, the P13K pathway is completely inhibited. So its clinical observation is in a lot of post-mortem AD brains is already there, that you see a phosphorylation of P13K pathway happening. So it's almost like when you have to come up with a cartoon, this is pretty much how I view this. Like what happens in a balanced stage is you will see this is always inhibited because it's very active. But whereas in a shift where in Alzheimer's, where you see a lot of tau tangles, this gets hyperactive. And because it gets hyperactive, insulin, even though it's available, is not able to reach the brain. That's the insulin resistance. The problem is not enough insulin production. The problem is not enough insulin reaching the brain. So that pretty much is what the hyperactive GSK3 beta mechanism is already shown in basic science. And this analogy was very well used with, again, a peripheral inflammation breaches the blood-brain barrier, compounding a lot of damage, which is happening here. As you can see in a healthy brain, insulin signaling, you will see that insulin going and coming out. But the problem is so much of things are happening with the inflammatory monocyte, the cytokines are getting activated. You'll see the insulin are still floating, but not able to register in the insulin receptor site. And this was, again, a very basic formula with going upstream with Alzheimer's as a metabolic crisis. So this is cerebrovascular dysfunction, abnormal neurodysfunction, amyloid tau, and reduced neuroplasticity. In all these angles, insulin resistance is playing a big role. And Wake Forest is also looking into this insulin resistance as a big type mechanism. So where my old research comes is, Dr. Kraft, Suzanne Kraft, who's our ADRC director, is a pioneer clinical research, clinical trialist. She has come up with this JAMA study where she published, where she gives Alzheimer people intranasal insulin. And somehow, when we give intranasal insulin for this Alzheimer people, the cognitive decline is improving. So the whole mechanism of bypassing the blood-brain barrier through trigeminal nerves is happening in her trial. As you can see here, it really reaches the central nervous system via an olfactory trigeminal nerve. So what she does is she collaborates with the company, and apparently it's just like a medicine. Every device is specific. So with one device, you get one benefit. With the other device, you won't get the same benefit. So it also depends on your mechanistics of your pump. So we are currently working on with one company called Aptar, which shows significant improvement. And this is how the JAMA paper was published. And what she has done is, if you give like 40 to 160 insulin units, have demonstrated improvement in the spatial memory and declarative memory and executive function in MCI and early AD patients. So that's an ongoing study in the same Alzheimer cohort. We have taken advantage of putting them into therapeutic intervention. So what really happens is, like I was telling you, it really bypasses the whole blood-brain barrier and reaches to the tracer level of olfactory and trigeminal nerves. And this pathway has been established and has been used. And this is the bigger question is like, okay, so this is happening if you avoid the blood-brain barrier concept, because there are so many amyloid and taus happening, can be reached in this particular highway. And this is simply telling you in the 12-month progression. In the placebo trial, you can see this is how much, and whereas the intranasal insulin in 12-month progression has halted significant aggressive white matter hypertension deposits. This has been done with amyloid and tau and also some of the biomarkers. But the bigger question the field was suffering was, why does it happen, and do we have any proof that the insulin goes in the brain? Until now, we don't even know that insulin goes in the brain. And this is when Dr. Kraft approached me, and she came to my office and we were having a conversation. Kiran, can we use your PET to show that insulin goes in the brain? And that too with the intranasal method. So this is like the underlying question was, efficacy was evident, but the mechanistic and direct target engagement require absolute proof. Take the same subjects, make them do it, and see whether is there any difference. And again, like I like to be challenged. When this question was coming to me, and I'm like, let's do it. And then this is pretty much the question is, very basic question. Can intranasal insulin enter the brain? Is this what we are seeing? We see an effect, but we are trying to understand why is this effect happening? And are there any differences in the brain uptake between the cognitively normal and impaired adults? So we started again because radiochemistry in me comes up. We just use gallium-68 because it's a better target to bind with the insulin, being a peptide. And gallium-68 has a 1 hour half-life. We tagged that. Very great. As you can see, it's very clean product. I don't know whether you can see it very clearly. It's 99% pure. And Krishna has very much helped me move this radiochemistry and this project move forward. So again, access to non-human primates was a key. So we used a vervets, like we did 6 males and 6 females. The only thing is we had to sniff the intranasal insulin in them, and they're already incubated. So we incubated monkeys and then we sniffed them. And the moment once the sniffing happens, we sniffed them twice in each of these nose and nostrils and started their incubated for 60 minutes. And then we did a 60-minute PET scan. We did with the same Aptar device that we use for people. And then like 1 puff per nostril within 2-4 minutes, we did 1, 2, waited 2 minutes, and then again did 2 more puffs. So it was only 0.4 millicuries. That's the max you could get because we were pushing it and they were not doing it by themselves. It's just a proof of concept that can go in brain or not. So the vitals were recorded. We did all the heartbeat, oxygen levels, blood glucose, and no significant changes were formed. And this is for the very first time we show that the insulin goes in the brain. When we sniff the intranasal way, not just lower, and it almost have more than 0.5 as their SUV numbers, showing that it is beyond the background. It does go in the brain with the help of PET. We showed that, and this is a cool PET MR images of a representative monkey. We did like 4 to 4, both males and females, and everybody showed very significant uptake in the brain. And one more cool thing about the time activity curve is it only goes by 20-30 minutes, stays for 40 minutes, and completely washes out by 180 minutes. And it does match the half-life of insulin. That's how much insulin half-life is. So it's only active when you do intranasal insulin very first 1 hour. And it may be matching very much with your intranasal insulin kinetics as well. So with this, we also did the dosimetry. And this is what FDA needs if you want to go in first in human trials. So we got this data, we showed FDA that it's very favorable, the animals were safe, no organ was exposed to more than 2.5 MSV, much lower than the 50 MSV, which is the annual limit. So now none of the organ got exposed more than 2.5. Vitals remain stable throughout 3 hours, and also after 24 hours. We made sure every single vital was tested in all these monkeys, and no significant difference were also seen between the male and female in our case, because they were age-matched, very healthy monkeys. With this, we went to humans. So the cohort was selected. The FDA gave us permission to do it in the MCI and AD cohort, and looking into the step one was very simple. We started with the baseline imaging, and second was we recruited them, of course. The fasting was done because we want to make sure that your glucose or insulin levels are not interfering with our interpretation. We made them sniff intranasal insulin because these are people, they can sniff by themselves, but still we made sure we had a nurse administrator there. The 6 sprays total via with the same Aptar device to give it into almost close to 4 for 4 IUs. The insulin units were administered through this method. And then we scanned them for a dynamic of only for 40 minutes because we understood from monkeys that it washes away by 60 minutes. So we don't need to scan them for all 3 hours. And then we tried to see the whole body PET CT. And this again, we made it in the GMP facilities, an added advantage because everything is done in the GMP space. It doesn't matter whether it is for monkey, mice, or human. We do, because we only have one facility, everything passes there, and it almost gives us a blueprint for human trials very easily. So as expected, there was no difference in the uptake between the vascular and the metabolic safety. Everything was very much fine. In the clinical trial space, there was no significant difference of the vitals. And you can see here the proof of concept. With the very first time, it does go in the brain. And more importantly, look at all the SUVs. It's more than 0.5. And across all my subjects, and showing that it is going into the brain. And when we did correlations into the brain, this is very cool. For the very first time, we saw that the cognitively normal people have much higher uptake when compared to the MCI, even though we have done it in the same level of administration. Every single subject got the same puff, but still it was different. So apparently there are receptors that have been blocked, and this is very first time we showed that. And very cool thing, I don't want to bring it up to your attention, that's the kinetic difference. For some reason, this is cognitively normal people have a higher uptake rather in the very first 5 minutes, and then it will drop down. Whereas with the MCI, it has a different kinetics. So there are also kinetic differences of the same intranasal insulin given through the nose. And you can see we have done it in all these different people, in different brain regions. So we have found like different correlations happens at the baseline, and I'm not going to go over in detail with all the correlation. We saw significant positive correlation with your diastolic blood pressure and the plasma insulin, saying the same thing, that intranasal insulin plays a key role as your vascular marker in Alzheimer's. And we have done the same thing at the baseline, and for your anterior cingulate, which has a higher insulin receptors, shows significant differences in people with MCI when compared to the cognitive normal. That also explains that this particular region, which will be more sensitive for the receptors, shows the difference. Again, the same more correlations. And I think this is the hypothesis we came up with. Why that does it happen? Because in healthy system, everything is straightforward, and maybe the plaques are disturbing it. Amyloid deposits or trauma or chronic inflammation or anything can disturb the whole process, and that might be the reason why MCI has a less uptake when compared to the cognitively normal. We are trying to establish in a bigger system, and now we are working with another company to see if their device is better, because we have used the same device that we use for the clinical trial. So far, the intranasal insulin PET, we are the first-in-class radio tracer, has been synthesized and shown both in monkeys and people, and no safety issues were identified both in monkeys and people. The whole body clearly shows that it goes in the brain, and time activity shows differences in the uptake, and cognitively normal people have higher uptake when compared to the MCI. And the baseline pulse pressure, plasma insulin, and the p-tau 217 correlated very well with the uptake for subgroups based on the cognitive status. Again, telling you that these people have some impaired insulin receptors. And that's the reason not everybody responds in the same way. Maybe this particular PET could be used as a tool before they go into the trial. Whether this person will be beneficial for a 1-year whole trial, or we can really identify early responders. And that's the plan we are moving forward with an R01 for this particular grant. And again, this would have not happened without the group. Thanks to all my group here. And this is my current group, Naresh, Krishna, Bhuvan, Mac, and Crystal. And I see Avinash just landed in. He's my last postdoc. Avinash worked with the monkey gallium tracer as well. And he's here with the UCLA and translational imaging program for all the things, and all my grant support consistently getting supported with a lot of smaller foundations as well. Like Impact AD is one foundation I got funded for my looking into the Alzheimer space in the early cohort. And all my lab here, thanks for everybody for making things move forward. And thus my family, without them, it would have not been possible where I am today. And I would like to take 2 minutes of your time, if that's okay with you, William and Shantanu, that we are building this particular division, which is very brand new. This year, the inaugural division started. We are looking into the division of research and clinical translation and imaging. That's called the direct eye. The bigger impact is to advance this path from basic to clinical. We are bringing all the imaging into one platform. It could be neuro, it could be cancer, it could be cardiovascular, everything. And we are trying to build in the pipeline. The reason why I'm pitching this to is we are actively recruiting. We are recruiting currently the cancer imaging faculties who have some K awards or anything, who are really wanting to have a break. Please come visit us and reach out to me. We are having all this. These are 2 examples I showed you where I have been successful in moving stuff from bench to bed. And I want people to use it in the cancer or cardiovascular space as well. And so this is pretty much a vision we are having to move the precision imaging and pre-symptomatic detection in all the different disease spectra. And it takes a village. Yes, it took me a whole country to make this happen. And thank you very much for your attention. Yes.
Well, I'll just anticipate some questions from others. What's the time from when you conceive these projects till first human study?
So it depends on the project. For my microtubule, it wasn't that bad because the tracer, the compound was already a dropout candidate. So it started in 2017 and my first in human was 2022. So almost 5 to 6 years. And we had it a stepwise way of going it. And yeah, but insulin was really a surprise for us. I think we did literally in 2024, and last year we were in people, because monkeys really helped us to convince FDA to go with that. Thank you. Yeah, thank you. I mean, you would think, yeah, I think we really break a lot of stereotypical norms, it takes things, but we moved into humans pretty quick. Yeah.
Kiran, great talk.
Thank you.
I had 2 questions for you. One was in the one reverse order, basically the way you presented. So in the intranasal insulin labeling, did you look at the FTG glucose? You might expect that perhaps the uptake was less in the MCI group because they're already showing FTG glucose abnormalities, for example.
That's a good point. I think we did see some correlation, that it was negatively correlated, but again, not all these subjects had an FDG glucose scan in them. I think that's the plan we are writing in an R01 to get their glucose uptake. But because we gave insulin so less, we did not see any change in their glucose level. So I think that was also something to keep in mind, that the blood glucose level did not change throughout the whole thing, because we are doing it in tracer level. And also wanted to avoid the diabetic complications. So none of my trial had diabetic people. So all were non-diabetic. Only the thing was we were looking at the MCI spectra.
The MPAC work was really fascinating. I wonder, did you look, you might expect that it could correlate with other structural measures of axonal breakdown, such as PTI. I imagine that's available for many patients.
Exactly. Yeah. I mean, you are right. You're spot on that. We are looking at that. And I think when you are talking this morning to Bill, I was getting this ideas of really looking into the DTI. And I mean, any injury in the axon is very common. It's just not implicated in Alzheimer's. I have a grad in Parkinson. Very similar thing is happening. Maybe it's just picking up a lot of neurodegeneration early on. And this is specific for Alzheimer's. That's where I started. But I'm also looking in Parkinson and ALS models as well. Yeah, we are.
Great. Talked about this morning in the traumatic brain injury area, microtubules are so dynamic. You're expecting this sort of progressive destabilization when the cause is an amyloid deposition, tau aggregation, but after injury that's discrete, you might expect maybe a peak of destabilization and a resolution potentially, and then maybe there are some people with repetitive exposure that go on to have progressive destabilization preceding tauopathy, for instance. So I'm hoping that this could be, I know you have traumatic brain injury patients that are young, but thinking about other patients who have microtubule destabilization from other causes and what patterns you might see from this tracer site.
It is exactly. No, I think, in fact, like I would want to bring something in your context, but for some reasons, once you have crazy depositions, when I really look into the exclusive Alzheimer people, not the MCIs people, so it almost plateaus. It doesn't go anymore. So it I'm thinking out loud, like maybe the destabilization is so dynamic, like one stage it stops just doing it. I think like it's the whole process is not even converting anymore. And that's what we have seen it in the rodent models as well. Once they have plaques and taus well established, the tracer is not picking up any more increase. So it's almost getting plateaued. And maybe for that reason, it's good to look at earlier stages where things are happening along with the co-pathologies like amyloid and tau, especially in your TBI cases. I think like because axonal changes are very common and neurons are getting affected, it'll be something to look into. Yeah.
I was curious, I think it was in the Irvit's when you looked ex vivo at the regional distribution of the microtubule tracer. Did you look in humans to see if there are particular regions that better differentiate your groups?
Yes, we got hold of only two human brain tissues as well. We only saw significant difference in the occipital cortex. The rest of the regions, again, human AD tissues are gold for us when you get it. I think and also the problem was we are not having comparison with age-matched cognitively normal people. So which was not very much age-matched, but in our thing, we only saw it in the cortex. Hippocampus did not show a significant difference in our human brain autoradiography.
But even if you look at the distribution of that tracer in the in vivo scans, do you see regional distribution changes that differ between groups?
Yes, we do. I did not show that. Yes, it's a good point. And when you do in vivo, there is a lot of regional distribution when I am binning it. So you don't want to take all the 60 minutes. When I did it like exactly from 30 to 45 minutes, you saw really significant differences in these regions. And by 45 to 60, it washes away, especially cortical regions. And two of this, occipital and frontal cortex, are significant microtubule destabilizations happening. And maybe I think I haven't looked into the substantia nigra to see if these people have anything rare, like it could be something to look into the Parkinson spectra there. Yeah.
GSK3 data is modulated by interesting animal study with you to look and see if
that's a good point.
Investigation
into that part, right? That's a good point. Maybe we could do it in the rodent studies to see that while it is there. Yeah, thank you.
I just have a few questions. One is the AAN template maps, and this is an imaging question. So, what Jason asked TBI, and to ask about the metabolic differences, cognitive normal, beta minus versus MCI. Did you see imaging changes, imaging differences? So, thickness in gray matter and that's
with the MRI stuff. So we are trying to correlate that. That's a very good point. We haven't been very successful in really getting it. And what we have seen is the cortical thickness is somehow correlating, is talking to the occipital cortex thing. Because MRI has always been done with the ALS imaging portfolio. It's only the cortical thickness is the one we are seeing it. And we're trying to look, again, the cohort is so small. It's only like 20 people. And with that, we couldn't see like very significant, but there is a trend. So the cortical thickness does talk to the occipital cortex uptake. As it increases, that decreases.
and the last study, did you show cognitive changes
In this,
Again, missed.
in the insulin.
Yes.
Oh, so that wasn't a part of. Exactly. So I think like that, because the questions I'm asking here is just to look into brain changes, and that's already done. Like like I said, the study is already done. We are going a step back and trying to understand why this is happening.
So I'll just
No, that's a good point to see the cognitive changes. I think we will do that in the thing. We did see in the cognitive index, it's only in the MCI people in one thing. In the correlations, I really had to move forward. But yeah, we did see some correlation with that.
Are there no questions? Any more questions? If not, let's Kiran.
Thank you.